So my name is Dennis. Welcome to this skill station, and we are going to learn about intraosseous access. So maybe I'll start by a question. How many of us have ever done an intraosseous access? By the show of hands. Yeah, so generally about 10% of everyone that is here. So this is a quick skill that is life-saving and that is very important for all of us to know, because there comes a time when you are struggling to save the life of a patient, and that patient you're not able to get intravenous access, so the other option you have is intraosseous access. The other question I should ask, who is it done for? Is it across all ages or is only for one particular set? Huh? Pediatric population? Any other suggestion? Yeah, so intraosseous access can be done across all age groups. I know we have only been doing it to the pediatric population, but we should now learn that we can do it across all populations. Before we discuss the sites where intraosseous access can be done, maybe the other thing we should discuss is what are the indications for intraosseous access. I know there is one I'll say and everybody will be like, wow, you mean? So what are the indications? I'll tell you the first one, then you tell me the others. The first one is 2 failed attempts of intravenous access. That's the one I knew everybody will say. So, yes. So I will say this. Okay, I will say this. That is what is in the books. But again, remember that that's what is written in the books. But again, you can always modify whatever is in the books based with your clinical scenario. For example, if you have a patient who is definitely in shock, you don't want to waste a lot of time looking for intravenous access when you're not seeing the veins. You do the first attempt, you have failed, don't even wait for the second attempt. Go straight to the intraosseous access, give some fluid boluses, the veins will expand, and then now you can put your intravenous access. So that is the first indication. The second indication, anybody with an idea? Anybody with an idea of another indication for intraosseous access? Resuscitation. Burns. Okay, that cannot be an indication because ideally that should be an indication to give fluids. If you get a vein, you will use the vein. You don't need to go to the bone. Huh? Any other indication you think? So basically, yes, exactly. If you are not able to visualize the peripheral veins, including your external jugular vein, then now you'll opt for intraosseous access. So if you're not able to visualize your peripheral veins, you're not able to even get your external jugular vein, go for your intraosseous access. And then unstable patients requiring urgent fluid resuscitation, you will need to do your intraosseous access. So what are the sites? There are many. Which is the commonest that we do? Which part of the tibia? Proximal tibia. That is the commonest. But there are many other sites you can do intraosseous access. Examples? So the sternum is one site. The clavicle is the other site. The proximal, the distal tibia. We have already said proximal tibia is the commonest. So the distal tibia. The distal femur is the other site. The iliac crest is the other site. Femoral, I've already said the distal femur. And then the humerus, proximal humerus. And then there's another site that is very also good called the calcaneus. You remember where it is? There's like a bone somewhere down there at the heel of the feet. Good. So that is the other site that you can do intraosseous access on. Good. So what are the contraindications? Yeah, so if you have skin infection at the site where you want to do intraosseous access, you don't want to proceed. If you have a recent surgery, for example, we all want to use the proximal tibia, but there was a knee replacement surgery on that knee. Will you proceed? No. Or you have a patient who has an above knee amputation, bilateral. It's not possible, isn't it? Yeah, so basically now you'll have to choose either other sites and make a decision on what to do. Great. So the technique is the issue, and usually it is not a very difficult process. If you know the skill right and you have your equipment right, within 2 minutes at most, you would have gotten into the bone marrow and you'll be able to start resuscitation of the patient. 2 minutes at most, you would have saved lives. So now you need to prepare your equipment. Of course, you'll need a gauze to sterilize the area where you want to place. You need gloves. You'll need a needle suitable for intraosseous access. So please, a needle suitable for intraosseous access should ideally be a big bone needle that is a bit strong. Sometimes we get this needle and we throw it away. Usually, how many of you do blood transfusions in their setups? That set usually comes with a needle, but we remove it and throw it away. Then a patient comes in shock, and we need the needle, and it's not there. So sometimes you can be wise and be saving them somewhere, so that when you need to do intraosseous access, you can access them. Alternatively, you can also request your organization to buy or order the big bone needles. Like for example, the one I have here is not very big, but for this purpose will be good. This is a gauge 18, gauge 18. So I think the needle size increases with the gauge reducing. So if by the time you get a gauge 16, should be bigger than this. You get a 14, should be much bigger than this. So of course, I think the 14 is the one which they use for domestic animals. But it will help you access the bone marrow. So once you have prepared your items, once you have prepared your items, of course, so I'm going to demonstrate that each one of you will pick a sample. So for purposes of this, we are going to use chicken thighs. I don't know if chickens have femur, but we'll presume that this is the femur part of the chicken. Chickens have femur. And the tibia and fibula also. They have, I'm not here to argue. I know people come from different parts of the country. And you started studying anatomy quite early. Okay, great. So, I'm going to attempt doing the intraosseous access on the distal part of this femur of the chicken thigh. Then you have many thighs. Each one of you will pick, attempt one, and we'll be recording to see how successful you are. So of course, first steps first. Once you locate your site, you would have spirit, you would swab. So upon swabbing, you need to locate a flat surface of the bone. But for the proximal tibia site, which is the commonest site, how do you locate it? 10 centimeters. It's not 10 centimeters, 2 centimeters. Actually, they say, is it 2 centimeters or 2 finger breadths? Should be 2 finger breadths, that's 4 centimeters. So it's 2 finger breadths below the tibial tuberosity on the medial surface. That is a surface that is flat. So 2 finger breadths, so I'm going to just hold that part, and each one of you can try to just hold there. I've already said it anatomically. Okay. So you put 2 finger breadths below the tibial tuberosity. Then you locate that flat surface. It's a smooth surface of the bone, and it will be very easy to go through. So once you have swabbed, okay, let's come back to the class. Once you have swabbed, whatever needle you are using, there is this part of the finger. It's very important for you to use that part to give it the force as you drill. Then your 2 fingers hold close to the needle tip, but you should leave a space that should be able to go into the bone marrow. Then, once you locate your site, you're sure you're on the bone, you just do a drilling. Just drilling like that. I'm already in. How long did that take? Less. Short time. And now, I can aspirate. If there is no blood, please understand, the chicken overstayed, but I believe there is some blood. You can see that? Yeah. Good. The lesson is over. It's time for practicals, unless there is any question. So we have a table there and a table here. Yeah, there is a question before we go. There is a question. Please scramble for the meat. Don't remove the foil paper unless you have very good sense of smell. We'll answer the question. Don't get gloves. Okay, there are some questions. Let's answer them, then we can start the practical. Great. Even the one I've used, somebody can still use it. There are gloves here. Please put on gloves and everything. So somebody has asked a question that I want us to get an answer. There's another box of gloves. Okay. I like the enthusiasm everybody wants to practice. Somebody has asked a question. Please let's answer this question, then you can practice. The question is, for how long do you want that intraosseous access to be there?
8 hours.
What is the answer? The first answer is here. What is the answer? Till you get an IV access. Till you get an IV access. So that prompts me to explain the next thing. So once you have your IO access, you need to secure it. Otherwise it will fall off. So the easiest way to secure it is, you just take a piece of gauze. Once you are sure you are in, you take a piece of gauze and wrap it around the needle. Wrap it around the needle firmly. Then there are some gadgets you usually have that sometimes expire on you, because everybody now is taking up family planning. They are called cord clamps. So the easiest thing is to just go where you have secured it and clamp it, pressing down so that it gives you the force to hold it next to the bone. So you clamp with a cord clamp. That's the first way. If you are not able to use a cord clamp, you can take the strapping and strap it to the leg, around and to the leg, just to support it there. Are we together? Yeah. Right. So let's do the attempt. Gloves. There is a box of gloves somewhere. There is a box of gloves on there. Another question, yes?
I wanted to find out,
Good. That's a very good question. Before you put intraosseous access, do you need to give local anesthetic? The answer is, it will depend with the clinical scenario. If your patient is unconscious, GCS of 8, you don't need to do that. But if your patient is conscious, of course there will be pain. So you can numb around and put your intraosseous access.
what are some of the complications that you like?
So depends, you can introduce an infection to the site, because remember you're pricking from the skin into the bone marrow. That's why you need to swab around it before you go in. And then the other things are, you could just prompt a fat embolism to occur. So it's something that you need to be aware about and probably do a wholesome management of your patient. Once you're in and stabilize the patient, if the patient has been unconscious for some time or you anticipate them to be unconscious for some time, you can do heparin prophylaxis just to avoid the clot formation and things like that. No, it's not possible. There is no bone that is long enough to go that much.
What about the other needles?
The bigger needles. Bone marrow. Yes, they are there. If you can procure them, they won't be able to go through. Remember, if you were able to go through, you would have chosen that side, the posterior side. But that side, the bone is very compact. So the moment you are in, it will not even allow you to go through because blood is already coming out. So you will not put more pressure. Very easy. Very easy. We can do it. Are you volunteering? So please do it. We are recording as you do it. Successful. Congratulations. Without a gun? Very easy. Like I demonstrated, same technique. As long as the bone is meant for bone marrow or you're using the bigger needle, it will just drill and go in. Remember that surface of the bone you have chosen is a soft surface, so it will just go through. It's just like when you're doing bone marrow aspiration. It's a procedure that is done routinely. So you still pick the same sites and use that to aspirate from your bone marrow. Yeah, so you see what you're doing this way. When you do it this way, your needle will fold. So the trick is, use this part to hold the tip of the needle. So this part of the finger to hold the tip of the needle, then you pick your flat surface like here. So once you are there, you rotate. So you are using this to put pressure, and this is rotating.
There is a pressure and then a give.
Like something.
You have warm skin. Good. You need a needle?
It's a needle. This what's that? It doesn't slide on the bone.
Great. Kibengia? There you pull out. Congratulations, you're doing well.
Where are we discussing?
There is a sharp box just next to you. Have you seen it? Uko ndani. Ndio hizo, ndio maana nimesema kama uko na mapua mzuri fungua. Uko ndani lakini.
Yangu tuone. Na imeingia, nimesikia hiyo giza.
Hapa naona bado nimeshika hapo. Congratulations, uko sawa? Lay down.
Kuna sharp box hizi tumeza kidogo. This one.
There's a baby one, no, there's a baby one here and there's a big one. There's a big one down there. We have sharp boxes. Please don't dump your needles. We have sharp boxes the other side. Ulikuwa hapa ndani ndo? Umeamba umeingia?
Kutoka pediatrics.
Umefaulu?
Ni kama iko sawa,
Iko sawa, iko ndani. Iko ndani ndio damu. Ndio damu.
ilikuwa yangu yani.
Oh, hiyo yako. Nikiona ya Amerika na furahi. Sasa, your ribs zimekatwa?
Okay. Na nataka kuikata.
Kisu iko hapo, umeona? Nafunga. You know, yours is next.
That's what I'm saying, 2 groups. Yeah. You have enough for we have?
Imetumika sana.
So much resistance that I'm not doing it.
So the reason is simple. You see what you see? You have located the site. I want you to use this part of the finger to push the needle down, and this two to just rotate. So this gives you the force, like you're pushing down as you rotate. You see, I'm already. Try again, somewhere else. Locate somewhere else and try. You can still do around there, just locate somewhere else. So you do that, then put your finger. See this part of the finger, this part on top here?
Yeah.
This gives you the force on top. Hata ishaenda, sio?
Yeah.
But
I
imeenda
think
kwa
right to the
nyama.
meat, yeah.
Imeenda kwa nyama. So you locate the flat surface of the bone. Do it here. And then try to use that. Yeah, good. So just do that. It will give a give. So you're applying some force as you go. Uko sawa.
Sawa jo. Imetumika sana.
Tuko tunaona
Hapa. Hapa.
Medial malleolus.
Pia unaweza fanya, si nilisema proximal tibia, distal tibia, distal femur. Inatoa clavicle. Sternum, head of humerus, iliac crest.
So you can go through there.
All those sides.
Yes.
Ayo.
I've never seen that. In fact, these guys haven't told me about this. Still this one. I just know about this.
Because this is what we have been doing commonly for children. But yes, sometimes you'll get a patient who has an above knee amputation. There is not that part. What do? Will you say you can't do an intraosseous? You'll pick a bone that is above. You don't have an IV access. The patient has amputation.
Bilateral.
The bilateral. This is amputated. This one has come with a bad degloving injury on the knee. So what do you do?
So
Come, you can do the iliac crest, you can do the head of humerus, you can do the clavicle, you can do the sternum. Yeah. So like for the clavicle, it's just midway in the clavicle. It's a very soft spot. Flat down. Just a soft spot, midway. Anywhere midway, not the terminal portion. Yeah. So as long as you're in the diaphysis, you're good. The head of humerus, any part around here, will go in very quickly.
the end of the femur.
So these are the same sites we do bone marrow aspiration.
The same procedure.
Bone marrow aspiration, the same sites for bone marrow aspiration. They are weak sites.
And then for the iliac crest,
The same. Iliac crest, as long as you go to your flat surface, go in. Anywhere. Just go in. Hapa hasa ndio the landmark. Two.
You are going very fast. In the iliac crest, do you have a bone marrow there?
yeah.
Because here I can trace it where it is. Here. But
Remember, the anatomy does not change. The bone is just changing the shape. It's either a flat bone or a round bone. The anatomy of the bone does not change. Inside the bone there will be a bone marrow. Before now you start getting before you start getting the osteocytes. Before now you come and get the periosteum. The anatomy of the bone does not change. So whether it's a flat bone, like the sternum is a flat bone, but it can still go.
And by the for the sternum, the landmark.
Hapo kwa manubrium tu.
Kwa?
Manubrium. So kuna the first part.
Then you are using the same gauge 18 to take bone marrow?
Yes. So you need a bigger needle. But the one for blood transfusion is gauge 18, but it's bigger than this.
Then I'm wondering, it seems not to be very hard procedure if you know what you are doing, but it's very highly charged. It's very highly charged. Taking the sample, you may find a physician saying it's 15,000.
It's because of the analysis
of the lab.
The analysis of the lab. That's why the cost is high, not the sample taking. The sample taking is a simple thing.
Even
you are not successful.
Not that much.
Of course.
Analysis can be like 5,000.
That is what is called the monopoly of knowledge. The fact that I'm the only one able to do this procedure, I can charge it the much I want.
You see, I'm in Machakos. Being in Machakos, I get patients I suspect to be having a cancer of the whatever, their blood. Then I send to consultant, this is 17,000. Then when I give the somebody to Angakani Machakos, they charge like 5,000. Then I'm wondering this procedure.
That's what I'm telling you, the monopoly of knowledge. Even you today, if you're able to do something nobody else is doing, you will charge well for it.
Now I understand. Thank you.
You have not succeeded yet?
Mimi nishafanya.
Nimesikia ukisema it's not giving or something.
No.
Ama ni breach imekataa kudeliver. Aya, so are we done?
Yes.
Is it not a risky procedure to dislodge the bone marrow?
To where? Where will it go to?
How do you get fat embolism?
That's what I say it is one of the complications of the procedure. You may get fat embolism, but it's not that straightforward. Because what is going to happen, once you put the IO, you're going to run fluid. So whatever thickness of fluid that was there is going actually to be thinner than it was. So the risk of fat embolism is not that high. You get the point? But if you leave it there for too long, now it can clog and cause a fat embolism. That's why you are resuscitating with the aim of getting an IV access. Once you get an IV access, you remove it. How many have succeeded? How many have not succeeded? Is everybody succeeded? Succeeded? By the show of hands, how many have succeeded? Okay, how many are still struggling? We are good. So that means now we'll be doing intraosseous lines. No, si unaweka local. Ama si umesoma procedural sedation. You sedate. Then you do your but it depends. Unaona patient akona BP ya chini. You don't want to give midazolam, you give something else. So you can give ketamine, sedate, then put your... Good, so now you can give me back my chicken thighs. Spirit. Kulikuwa na sanitizer mahali. I believe there is a sanitizer somewhere. Sharps box is here next to me. Gloves, there is a dustbin, the other side. The sanitizer is on the last table. Please bring back my chicken thighs. And thank you very much for participating actively in this skill session.
Thank you.